Good evening, all. Welcome to the latest edition of Spice Route India Classroom. So we've come back after a long break, and it's great to announce that this is the first session that is being hosted by the Maharashtra State Chapter. Also, the State Chapter has expanded now, and we have a State Secretary, a State FM 360 Coordinator, and a PG Coordinator for the state. Maharashtra team is led by Dr. Darshana, who practices in Mumbai. And then we have Dr. Ramya and Dr. Joshi. We have Dr. Kritika, who practices in Pune. I welcome all of you to this session. We'll have a case presentation by Dr. Joshi. And, the moderator for today's session is Dr. Kishore Madhwani. I want to welcome Dr. Ramya. She is the State Secretary for the Spice Route Maharashtra State Chapter. She will be hosting today's session. I welcome you, Dr. Ramya. Over to you.
Thank you, Dr. Jyotika. Thank you for having us. So this is our first Spice Route classroom session hosted by Maharashtra. And firstly, I would like to welcome Kishore Madhwani, sir. Just 1 minute of slide I would like to put up. Is my slide seen?
Not yet. You can read from it, no issues.
Okay, okay. So, good evening, sir. Dr. Kish, yes.
Good evening, everyone.
Hello, sir. Sorry, we are having some technical issues in this.
No issue, no issue. Good evening to all.
Thank you, sir. As we all know, Dr. Kishore Madhwani, sir, is a senior physician, and his expertise and special interest includes occupational health and ergonomics and wellness consultant. He's currently working in South Mumbai. So thank you, sir, for guidance, for your guidance, or should I say thank you for playing the chair. Next, Dr. Jyotika, welcome. You are the National Secretary, and thank you for always literally being the leading light. Thank you for having newbies like us host a session and go forward. Dr. Darshana, State Lead of Maharashtra, thank you for this opportunity. Thank you for organizing more state sessions like this. Dr. Joshi is a final year resident in in the Department of Family Medicine in Holy Spirit Hospital, Mumbai. Dr. Joshi, when we discussed about what case we should discuss in the Spice Route classroom, first thing we wanted to think of something which will be beneficial to all the exam going students. At the same time, give them a more of a confidence as to face their examiners boldly. So first thing that came to our mind was CNS. So CNS, we want to bust the myth that it is not very difficult. All you have to follow is a set of rules, and once that is done, it will be very easy to approach. So that is what we are going to do today. And among the special guests we have Dr. Rashmi ma'am. Ma'am, what an honor. So welcome. Please give us your guidance and feedback. Mohan sir, thank you for joining us. No words or introduction necessary. Thank you, sir, for always being a guidance. And let us start with the session. Over to Dr. Joshi.
Hi everyone. Let's start our session. So, my patient is an 85-year-old male who came with main complaints of sudden onset giddiness, deviation of angle of mouth to the right side, slurred speech, left-sided upper limb and lower limb weakness from 12:45 p.m. on 24th of August 2022. So, patient Mr. X, 85-year-old gentleman, he was apparently all right until that afternoon, sitting on his bed and talking to his son, when he suddenly developed a sudden onset of giddiness at around 12:45 p.m. And this giddiness is non-vertiginous in nature, and it was not associated with any headache, vomiting, tinnitus, jerky movements, or any loss of consciousness. He then had deviation of his angle of mouth to the right side, which was associated with slurring of speech, drooling of saliva, but there was no associated loss of taste. There was no history of any loss of smell, vision, double vision, decreased sensation of the face, decreased hearing, difficulty in swallowing, shrugging of shoulders or tongue movements. After that, he noticed weakness of his left upper limb and as well as lower limb. This weakness was sudden in nature, which was occurring simultaneously in both left as well as upper and lower limbs, and this progressed completely until he could not move the whole of his limb. There was no history of any numbness or any pins and needle sensation. After this, he was then brought to the hospital by his family. Negative history, there was no history of any chest pain, palpitations, no history of any trauma, no history of any loss of bowel or bladder control. Past history, there were no history of any similar episodes in the past. History of mild symptomatic COVID illness was present in March 2021. This was managed at home and he recovered asymptomatically. My patient is a known hypertensive for the last 8 years and he's on tap amlodipine for the same, about 5 milligram in the morning, and he's on good compliance. Family history. So there are in total 4 members in his family. He himself, his wife, one son, and a daughter. His father died due to stroke at the age of 65 years, and he was also diagnosed hypertensive. Personal history. His diet, he is a vegetarian in diet, non-alcoholic, non-smoker. His bowel and bladder habits were all normal. There is no high-risk behavior. His occupation is a retired bank manager. Drug and allergy history. There are no history of any allergy to any drug or any food substance as such. Socioeconomic history. He has an average monthly family income of rupees 50,000. He lives in a pakka house where there is no overcrowding with good lighting as well as sewage system. He belongs to upper middle socioeconomic class, which comes under modified Kuppuswamy class 2. So the summary of my case: an 85-year-old gentleman, hypertensive, with a family history of stroke, came with complaints of sudden onset slurring of speech and deviation of angle of mouth, left-sided weakness since afternoon on 24th of August 2022. My differential diagnoses include acute ischemic stroke, then hemorrhagic stroke. Coming on to general examination, he was conscious, oriented to time, place, as well as person. He was lying in supine position. There was no pallor, cyanosis, icterus, clubbing, edema, or generalized lymphadenopathy. His pulse rate was around 68 beats per minute and it was regular in rhythm. It was of normal volume and character, and it was also bilaterally symmetrical with no radiofemoral delay. And also peripheral pulses were all felt well. His BP was around 140 by 90 millimeter mercury, which was measured in the right upper limb in supine position. He had a respiratory rate of 14 per minute, and it was abdominal thoracic type. There was no engorged neck veins or enteromegaly. JVP was not raised, and there was no carotid bruit. Examination of CNS. His higher mental functions, he was conscious, cooperative, and oriented to time, place, and person. He is right-handed. His GCS is 15 by 15. Memory, intelligence, and comprehension were all normal, and his speech was slurred. On cranial nerve examination, the olfactory nerve was intact. Optic nerve showed a visual acuity of 6 by 6 on both right and left sides. He had bilateral pseudophakia. Pupils were equally reactive to light as well as accommodative. On visual field testing, he had left homonymous hemianopia. Fundus was within normal limits. This oculomotor, trochlear, abducens, as well as the trigeminal were all intact. Facial nerve, on inspection, facial asymmetry was present. Then there were wrinkles present on the forehead. No eyebrow droop or difficulty in closing eyes was present, but there was drooping of corner of his left angle of mouth. The patient cannot whistle as well as blow out on the cheeks. On sensory examination, the taste sensations were preserved in the anterior two-thirds of his tongue. He had an intact vestibulocochlear, glossopharyngeal as well as vagus nerves. The spinal accessory as well as hypoglossal were also intact. Now coming to the motor system examination, this patient had the tone was normal on the right side for both upper as well as lower limb, whereas on the left side, tone was increased in the upper limb as well as in the lower limb. Bulk, it was normal only, both right and left side. Power, so over the right upper limb as well as the left upper limb, the power was 5/5 on the right side, but the power was 0/5 over the left upper limb. Power was about 0/5 over the left lower limb also. Reflexes, so the superficial reflex, abdominal reflex.
Just 1 minute of interruption. When we measured the bulk, just emphasize on why we have written it only on theoretical purpose, if it's okay. Yeah.
Only for completion.
Yes.
So reflexes, abdominal reflex was present on both right as well as left side, and the plantar reflex, it was flexed on the right side, but it was extensor on the left side. Deep-tendon reflexes were all exaggerated over the left side. Sensory system examination. Sensations are present over the right upper limb and the lower limb, whereas sensations like touch, pain, temperature, and vibration, they were all absent over the left upper limb as well as lower limb. Cortical sensations, we couldn't test them. Cerebellar functions could not be assessed. Gait could not be assessed. His cranium and spine were all normal. There were no meningeal signs. The NIHS score of this patient is 21. Now, brief system examination. His chest, CVS, abdomen were all normal. So there were in CVS there were no added sounds. Respiratory system also there were no added sounds. Hair entry was bilaterally equal. Abdomen was also soft with no guarding region to tenderness. Summary of my case: an 85-year-old gentleman, hypertensive, with a family history of stroke, came with complaints of sudden onset slurring of speech and deviation of angle of mouth, left-sided weakness since afternoon on 24th of August. On examination, he was conscious, cooperative, with left homonymous hemianopia, UMN type of left 7th nerve palsy, with left-sided weakness and exagerated reflexes. My professional diagnoses include ischemic stroke and hemorrhagic stroke.
नहीं होगा जब तक वॉल्यूम नहीं आएगा unless we increase the volume.
Okay, am I audible?
Yes, sir.
Yes, sir.
Yeah, actually, it's a very nice presentation by Josie. She has outlined very nicely, so we can visualize the whole thing. I just like to make a few comments that she has mentioned. Josie, you mentioned that 12:45 this occurred, but
Yes,
it should come out. I think the patient reached the hospital around 1:15 or something like that. So that is not very clearly visible here. The patient reached the hospital what time?
So the patient reached around 1:30 ko he had reached, sir.
12:45. Now that should come out here, in the history that you give, because that the examiner is definitely going to ask you, how much
Okay.
time has elapsed, because our treatment management all depends since the onset of the event and where the medical help has come, what time the doctor see, what time you reach the institute. Reaching the institute in the time frame is very important in case of strokes. And nowadays strokes are more because of the COVID-19 making the blood thicker. So, we are getting more incidence of strokes almost everywhere, and even heart attacks, all related to more blood clots. So basically, the time frame is very important, very crucial. That should have been mentioned here. Anybody else has anything to mention?
Sir, I wanted to add a few points. So one thing is, in examination, I wanted to be as quick as possible. So when we included bulk, tone, and everything, I do not want our students or doctors or anybody to, when somebody comes with a stroke, stand there with a measuring tape and to see what is the change in bulk. So like how we say time is money, when it comes to stroke, time is brain here. So this was just included because for exam going students, the CNS case format needs to be followed. So in reality, don't do this bulk reflexes much. So try to conserve as much as time as possible. So that is what I wanted to emphasize.
Can I say something? I couldn't hear the complete presentation. I don't know whether the presenter summarized at the end of history taking. From the exam point of view, I think you are expected to summarize your history before proceeding to examination.
Josie, maybe you can read the slide, no? Summary slide.
No, what I'm asking is, was the case summarized after the history taking?
Josie, you're on mute.
An 85-year-old gentleman, hypertensive, with a family history of stroke, came with complaints of sudden onset slurring of speech, deviation of angle of mouth, and as well as left-sided weakness since afternoon of 24th of August 2022.
Okay, great.
Josie, you have a question from Rashmi ma'am. Could you please elaborate the diagnosis for the sake of exam? Also from history, just from history, how do you differentiate an ischemic stroke from a hemorrhagic stroke?
So, to differentiate an ischemic from hemorrhagic, so if the patient is hypertensive, like from the history we can say, like if the patient is hypertensive and not compliant with medication and all, then he has more chance of developing a hemorrhagic stroke. But if he is compliant with medication, then it may not be, chances for the hemorrhagic stroke are less. Then another thing is the onset. That is mainly for hemorrhaging. Then
the most important point is the onset and the progression
Onset.
of
yes,
events
onset
in a
and
stroke.
progression.
Onset and the progression of events. So how do you differentiate between hemorrhagic and ischemic depending on the onset and progression?
Okay, so ma'am, if it's a thrombotic stroke, the onset will be mainly during, like it will be wake up stroke while he might be sleeping. Then when he woke up, he had this weakness. So during this 4 a.m. to 5 a.m. that time, there are more chances of developing a thrombotic stroke. And this hemorrhagic and embolic will happen mostly when he's doing some activity. That is with regard to the onset and progression of symptoms. In case of thrombotic stroke, there will be a worsening of the symptoms over the time period. And in case of an embolic stroke, the symptoms he will be having a full complete deficit in the beginning only, and there will be a gradually over 24 to 48 hours he will have a resolution of symptoms. In case
So
of
what about
hemorrhagic
hemorrhagic stroke?
yeah, in case of hemorrhagic stroke also, he will be having complete deficit in the beginning. Because of the in case of hemorrhagic stroke, ma'am, there is a gradual worsening of symptoms only.
No. As you said, it will be maximum itself.
Maximum.
The beginning itself, there will be maximum.
Maximum.
But the progression, as you said, differs from that of the embolic.
Okay.
That is how there is a difference. Now, my first question about how do you tell the diagnosis in a proper exam format?
So, 85-year-old male with complaints of
No, I just want the diagnosis. I only want the diagnosis.
So it is a case of acute cerebrovascular accident. Probably ischemic.
What is the pathology? You start from anatomy, pathology, then the etiology. Okay, so it is a left-sided hemiplegia.
Left-sided hemiplegia.
With UMN facial palsy, right?
Yes, with left-sided hemiplegia with UMN facial palsy.
Yeah, most probably due to a cerebrovascular accident. Which
Most
may
probably,
be in this case, from the history, what do you think it could be? Hemorrhagic or ischemic?
Ischemic or hemorrhagic. My first provisional diagnosis is ischemic. Second one is hemorrhagic.
But the points you said, did you tell about the progression of the weakness in the history?
So
you said it was a sudden onset, complete weakness, right? And it was around 12:45 at what time? Noon.
Noon time. It was noon time.
So then, how did you say it is ischemic? Now you only said that the differences between ischemic and hemorrhagic, right?
Yes. Ma'am, actually from his MRI films and all, they were suggesting.
Yeah, MRI films you are not allowed to see during exams.
Okay. So otherwise, ma'am, from the history, it seems mostly a ischemic stroke.
So in the
hemorrhagic
history,
stroke.
you should have explained the progression of the symptoms. Like,
Yes.
was it a sudden onset, complete weakness of both upper and lower limbs, or did it start and then progress over the 1 hour or half an hour while transporting to the hospital, or how it had progressed? That you had not mentioned.
Okay.
You just said there is a sudden onset left-sided weakness. Maybe that could have given. And the other thing which you said, whether the patient was doing any activity while this happened.
So he was
So
sitting on
that
his.
you didn't mention in your history. What was it?
He was just sitting on his bed, talking to his. Just he was sitting on his bed, and his son was also sitting nearby. They were talking.
Okay.
Dr. Joshi, why don't you put up the first slide where we have talked about progression, just in case. Let's clarify. Yeah. Nice. Yeah. So when, read this out as to how it progressed,
So
how he
he
had
was
weakness and everything. Yeah. Answer, it's okay.
So he was sitting on his bed and talking to his son. Then he developed sudden onset giddiness. Then after that, he had deviation of angle of mouth to the right side. Then after that, he had this weakness. He then noticed weakness of his left.
So that means it was a progressive thing. It was not a. See, suddenly there was a slide, but she had a. You should not mention the word giddiness. Actually, giddiness has so many meanings for each person. So then he had a slurring of speech. Then he had a deviation of angle of mouth. Then he had a weakness which was progressing. So it is actually a progressive weakness over maybe 1 hour or so. So then in your differential diagnosis, when you say ischemic, it makes sense.
Okay.
So the diagnosis should be more clear. It should be elaborate like this. That is a left-sided hemiplegia, most probably with a UMN facial palsy, most probably a cerebrovascular accident of ischemic origin, ischemic type, and with hypertension. Right.
Okay.
So all these things should come in your diagnosis. For an example, for the practical purpose, as Dr. Earlier mentioned, for practical purpose, this is all you have to be very quick and you have to judge very. There is no role for this elaborate diagnosis. You just have to know whether it is an ischemic or hemorrhagic stroke to manage.
Okay, ma'am.
Okay. And in examination, how can you differentiate between a hemorrhagic episode or a what? And
ischemic or thrombotic.
Ma'am, excuse me, ma'am.
Suppose you are going for a home visit. Suppose you are going for a home visit to an elderly patient. They say that the patient is not moving this same history is being given. Now, you cannot do an elaborate CNS examination there. What examination finding, and they are not willing to bring to the hospital. There is no CT scan or MRI. So the thing is, you can start an antiplatelet or not start an antiplatelet. How will you decide?
I can do a fundus
examination.
I can do a fundus examination and see if he's having any papilledema, which is more suggestive of a hemorrhagic stroke.
Before the fundus, something even without an ophthalmoscope.
Otherwise, history I can ask whether in history.
Sometimes the pupil itself gives you the clue.
Okay. Whether the pupils.
When there is, how will the pupils be?
Irregular. Pupils will be irregular. In raised ICT, the pupils will be irregular. There will be constriction of pupils.
Yeah, there can be an anisocoria. There can be pinpoint pupils. They may not be reacting to light. All these things can be there if there is a raised intracranial tension.
Okay.
So that is one thing. And in I'm just talking from the examination point of view.
Yes, ma'am.
So how will you explain this left homonymous hemianopia? Where could be the lesion be? In the right MCA, left hemianopia and dysarthria.
So left hemianopia, so the lesion seems to be in the like where the optic radiation is. Right optic radiation is affected. So it
Do
mostly.
you commonly see that in a MCA territory infarct? MCA territory.
Commonly
Hello.
it is not seen, ma'am. Commonly it is not seen.
Hello.
Hello, ma'am. Hello.
Hello. Am I audible?
Yes, ma'am.
I think my net is going off.
Yes,
Yes, you
ma'am.
are
Yes,
audible.
we can
Please
hear you.
continue.
Yeah. So you said about the optic radiation,
Yes.
right? So optic radiation is in anatomically. Where is optic radiation?
Cortex.
Cortex is a very
Posterior.
broad.
Yeah,
Cortex
posterior
is a
part of
very
the
broad.
optic radiation
Now,
they are located.
what happens with the CNS cases? It is almost like mathematics. So if every points are there, and if you know very well the anatomy and all this, it's very easy as mentioned in the beginning. So if you are very clear with where each thing is, you just need to connect the dots to get the diagnosis. Okay, so when you are mentioning a hemianopia, you should be able to explain how it has, how hemianopia has come here. Are you sure it is a right homonymous hemianopia?
Yes, ma'am. It's a left. There was, yeah, he had a left hemianopia.
Sorry, left homonymous hemianopia.
Yes.
So you should know the optic nerve tract. You should know the facial nerve tract. All these things when you mention these things, because only then we'll be able to explain the right MCA territory. In fact, with you have to connect this with the hemianopia, right? Which are the areas that MCA supplies?
So
And where is optic? No, I'm not saying that you are wrong. You just have to explain all these things.
yes, ma'am. Hello.
Okay, so for
Yes,
exam,
yes,
please
we
be
can hear
prepared
you.
with all these things. Okay.
Yes, ma'am.
Josie, show ma'am the slide where
Yes.
we have discussed the arterial supply, what areas are.
So this is
Yeah,
a
all
slide
these
show.
things are with you, but you should be able to explain it to the examiner at the right time without prompting. That is
Okay.
where your presence of mind during a practical exam comes in. Okay.
Yes, ma'am.
You have to explain how it happens. Yeah, tell me. You have very clearly made all the slides, but why didn't you tell all these things?
So, ma'am, this MCA, it supplies the lateral aspect of the cerebral hemisphere, the frontal, temporal, as well as the parietal lobe, and also the subcortical structures, which are including this internal capsule, posterior portion, then the corona radiata, then globus pallidus, outer part, then most of the caudate nucleus as well as the putamen.
Okay. So, how do you explain the homonymous hemianopia now?
So, it is supplying the so it's applying the parietal lobe. It is applying the
I think when you made the slides, you should be fluent with the slides also. Okay. For example, I'm not criticizing you, but when you go for an exam, you should be well prepared at all aspects, with all aspects of the case. Okay. No problem. Just brush it up once again. Okay.
Okay.
Don't take this as a criticism. It's just how you have to face an exam. That is all. Okay.
Yes, ma'am. This MCA is involved in the occipital lobe also from here. This yellow area. Hello.
Yeah, whatever you are telling, tell confidently and explain confidently. Okay. That is the point that I want to stress. I'm not saying that you don't know. You know, but you have to be very confident and tell when you are presenting in an exam.
Yes,
Now,
ma'am.
I think let's move on to the clinical aspect. I think there are practical aspects also to be discussed.
Okay.
Dr. Joshi, we have to also discuss about how we came to the diagnosis, what imaging and all that. So briefly, why don't you tell us and then we'll start the discussion.
Investigations I will start.
Yes. Okay.
So the patient had a hemoglobin of about 15.6 and Baki CBC was overall normal. His HbA1c serology were all negative. ECG sinus rhythm and no significant changes. His MRI revealed areas of ischemic core in the right parieto-occipital lobes with hypoperfusion. Then MRI diffusion weighted imaging showed areas of ischemic core in the right parieto-occipital lobes with hypoperfusion. Then CT perfusion studies revealed a penumbra mismatch volume of 30 ml as well as a mismatch ratio of 2.2. So with that, we came to this diagnosis of left-sided hemiplegia, left human facial palsy, and left hemianopia and dysarthria due to acute right MCA territory ischemic stroke in a non-hypertensive with GCS of 15. Treatment received. The patient was received in the ICU at around 2:15 p.m. Then he was given this injection multiplies 50 mg. It was infused, 10% is infused over 1 minute, and the remainder was given over 60 minutes. Since there were no complications, he was then gradually shifted out to the ward, and he was initiated with physiotherapy as well as tab echospin 150 mg. He then underwent MRI, which showed no new finding, and he was discharged home after 4 days. He was advised to undergo further testing with serum homocysteine, serum lipid profile, 2D echo, carotid artery imaging, but he requested that he would follow up on OPD basis in view of fistula at home. The condition of the patient at discharge, he had complete resolution of dysarthria and hemianopia with partial facial and left-sided weakness, power of 4/5. That's all, ma'am.
So Josie, coming back to ma'am's question, mainly her point was like, we initially thought he comes with a left-sided weakness, left-sided upper limb weakness, left-sided lower limb weakness, dysarthria. He doesn't say anything to do with the vision. When you examine and you find that he happens to have hemianopia. So ma'am's basic question was, how do you tell that? How can you explain MCA territory in this? Correct. MCA territory is most common. He came to you with left upper side weakness, lower limb weakness, deviation of angle of mouth. Correct. So everything sounds like it is related to internal capsule right now. Now suddenly we are adding one more finding, which is again hemianopia. So how do we fit this? So what ma'am is trying to tell you is probably you have to think beyond internal capsule. Probably something else is also affected beyond that. So that's what ma'am was telling, that whatever it is following, it's like mathematics. And if there is hemianopia, the lesion is not just internal capsule. There could be other involvement as well. Most probably occipital. Okay. Ma'am, can you hear us, ma'am? Would you like to add anything?
Yeah, I can hear you.
Yes, ma'am. Yes, ma'am.
Yeah, continue the discussion.
Yes.
Yeah.
So definitions mainly. Stroke, it is a clinical syndrome of rapid onset of focal deficits of brain function, which is lasting for more than 24 hours or leading to death. Transient ischemic attacks, These are clinical syndrome of rapid onset of focal deficits of brain function, which resolves within 24 hours. Then progressive stroke, a stroke in which the focal neurological deficits will worsen with time. It is also called a stroke in evolution. Completed stroke, a stroke in which the focal neurological deficits persist and do not worsen with time. This is a slide showing the epidemiology. There are about 13.7 million new strokes of all types each year. Every fourth person aged over 25 years will suffer a stroke in their lifetime, and it is the second leading cause of death worldwide. Ischemic stroke, of all strokes, about 88% are ischemic, 12% are hemorrhagic in nature. Then strokes can happen at any age. Each year, 52% of new ischemic strokes will occur in men, and 48 will occur in women. This is a journal showing the stroke in India, systematic review. From that, the incidence of stroke in India is about the crude incidence of stroke range from 108 to 172 per 100,000 people per year. The prevalence was from 26 to 757 people per 100,000 people per year, and 1 month case fatality rates was from 18 to 42%. So now these are the risk factors for stroke. So there are fixed risk factors as well as modifiable risk factors. Fixed risk factors include age, gender, male more than female, race, heredity, previous vascular event like MI, peripheral embolism, high fibrinogen, and also modifiable risk factors like hypertension, heart disease, diabetes mellitus, hyperlipidemia, smoking, excess alcohol consumption, oral contraceptives. Common types of stroke, mainly two types, ischemic stroke and then hemorrhagic stroke. And inside ischemic comes embolic as well as thrombotic strokes. Etiology of ischemic stroke, first of all, the thrombotic etiology includes lacunar stroke, large vessel thrombosis, and hypercoagulable disorders. Embolic stroke, the etiology includes artery to artery, it is carotid bifurcation, aortic arch, embolus from these regions. Cardioembolic, that means originates from the heart. The reasons could be atrial fibrillation, myocardial infarction, mural thrombus, bacterial endocarditis, mitral stenosis, and paradoxical embolus. Now let's see what is ischemic penumbra. Ischemic penumbra refers to the tissue which is surrounding the core region of infarction, which is ischemic but reversibly dysfunctional, maintained by collaterals. It can be salvaged if reperfused in time. It is the primary goal of all revascularization therapies. This is a slide showing the pathophysiology of stroke. So when a thrombus or embolus comes, it will lead to hypoperfusion, ATP depletion. Then there will be a failure of the sodium-potassium ATPase pump. Then there will be membrane depolarization and cytotoxic cellular edema, which will lead to glutamate release and calcium entry. There will be activation of lipid peroxidases, proteases, and nitric acid synthase. Then there will be destruction of the intracellular organelles, cell membranes, etc., leading to liquefactive necrosis. Hemorrhagic strokes are of two types, intracerebral and subarachnoid. They have got higher mortality rates when compared to the ischemic stroke. Now let us see the history approach. We have to ask for the onset as well as the progression of neurological symptoms, completed stroke, or whether it is a completed stroke or whether it is a stroke in evolution. Then we have to ask for the history of any previous TIAs as well as Amaurosis fugax. Then we have to ask for the history of hypertension and diabetes mellitus. Also a history of heart conditions like arrhythmia, rheumatic heart disease, and prosthetic valves. Then we have to ask the history of seizures, migraine, anticoagulant therapy, history of oral OCPs, history of any hypercoagulable disorders like sickle cell anemia, polycythemia vera, also substance abuse like cocaine, amphetamines, etc. So there are mostly, we can say, 5 vascular syndromes: anterior cerebral artery syndrome, middle cerebral artery syndrome, posterior cerebral artery syndrome, lacunar syndromes, and internal carotid artery syndrome. So this is the figure showing the blood supply of ACA, MCA, then posterior communicating artery and all. And here you can see the motor homunculus, the middle cerebral artery, its blood supply shown in these orange colors, and you can see also this ACA supplying the frontal lobe. Now let's see the lobes and their functions. So parietal lobe is mainly involved in language and touch. Occipital lobe is mainly involved in sight. And the cerebellum, we can say, it is involved in balance and coordination. Frontal lobe mainly behavior, thinking, etc. Temporal lobe is involved in hearing, learning, feelings, and brainstem is involved in breathing, heart rate, and temperature. So this is a slide which is showing the localization. So when the cortex is involved, the site of lesion is cortex. Patient will have aphasia, bladder involvement, cortical sensory loss, denial, epilepsy, flaccid mono hemiplegia. Then we can see the internal capsule, which is the most common site. In that case, patient will be having a dense hemiplegia and also hemianesthesia, hemianopia, and marked spasticity. If the thalamus is involved, there will be flating hemiplegia or hemiparesis that will be in the side opposite to the lesion. Also, there will be loss of superficial as well as deep sensations. Then if midbrain involved, there will be Weber syndrome and Benedict syndrome. I'm not going into details. Then if the pons is involved, there will be Millard-Gubler syndrome, Fowell syndrome. Then medullary lesion will lead to medial medullary and lateral medullary syndromes. If the same spinal cord is involved, patient will be having a same-side hemiplegia with no cranial nerve lesion. So this is again a table which is showing the site involved. So if there is paralysis of opposite foot and leg, it is mainly the motor leg area. And if the patient is having a impairment of gait and incidence, etc., there will be inframedial frontal striatal ridge involvement. If contralateral face, arm, and leg are involved, there will be somatic motor area will be involved. If there is sensory impairment of the same area, then somatic sensory area will be involved. Homonymous hemianopia. If it is involved, optic radiation will be the structure that is involved, that is located deep to the second temporal convolution. These are the consequences of the localized cerebral hemispheric lesions. So if the lesion is in the occipital lobe, patient will be having visual field defects, visual agnosia, hallucinations, alexia without agraphia, visual anosognosia, etc. And if the temporal lobe is involved, patient will be having amnesia, then Kluver-Bucy syndrome. If the dominant hemisphere is involved, there will be transcortical sensory aphasia, word sense selection, anomia, etc. Coming to the parietal lobe. So if the parietal lobe is involved, there will be simple somatosensory disturbances, contralateral sensory loss, contralateral pain, paresthesia, etc. And if the lateral aspect of the parietal lobe is involved, there will be parietal apraxia, finger agnosia, acalculia, right to left disorientation, lateral alexia, conduction aphasia. Now coming into the anterior circulatory syndrome. So ACA mainly supplies the medial aspect of the cerebral hemisphere and subcortical structures including basal ganglia, fornix, anterior portions of the corpus callosum. The most common characteristics of ACA syndrome is contralateral hemiparesis, sensory loss with greater involvement of the lower extremity, etc. MCA supplies mainly the lateral aspect of the cerebral hemisphere and subcortical structures. Then occlusion will produce extensive neurological damage with significant cerebral edema. There will be increased intracranial pressure that will lead to LOC, brain herniation, possible death. The most common characteristics of MCA include contralateral spastic hemiparesis, sensory loss of the face, upper extremity and lower extremity, with the face and upper limb is more involved than the lower limb. There will be unilateral neglect, anosognosia, apraxia, and spatial disorganization. Homonymous hemianopia is also a common finding. In MCA, we can say it is the most common site of occlusion and stroke. If the PC is involved,
Dr. Joshi, slow down a little bit. Go to the MCA slide, please. So do you think your patient has all these symptoms? Is it fitting or?
Yes. So my patient had he had hemiparesis and also he had sensory loss of the face, upper extremity as well as lower extremity. Then he also had homonymous hemianopsia.
He has homonymous hemianopia. So he has left side weakness, both upper limb, lower limb, face, and he has homonymous hemianopia as well. Okay. Yes. So one thing we are not able to explain here is the dysarthria part.
Yeah.
So yes,
so
go ahead.
Dysarthria, he had a facial deviation. So the nerves which are mostly involved in dysarthria, one of the nerves involved in dysarthria include the facial nerve. Other nerves can be hypoglossal, then glossopharyngeal and vagus. So the patient had a facial nerve was involved. That is why he had a deviation to the left side.
Okay, so he had no aphasia as such.
He had no aphasia. It was mainly a dysarthria, which might be due to the facial nerve lesion.
Okay, go ahead. Thanks.
PCA. So in case of PCA, the occlusion, if it occurs proximal to the PCA, it results in minimal defects due to the collateral blood supply. And occipital infarction produces homonymous hemianopsia, occlusion, visual agnosia, condition in which a person can see, but he cannot recognize or interpret visual information due to a disorder in the parietal lobes. Temporal lobe ischemia results in amnesia. Now, coming to the internal circulatory syndrome, here there will be occlusion of the internal carotid artery. It produces massive infarction in the region of the brain supplied by the middle cerebral artery. The ICA the ICA supplies both the MCA and ACA. If the collateral circulation to the ACA from circular villus is absent, there will be extensive cerebral infarction in the areas of both the ACA as well as MCA. Significant edema is common with possible uncal herniation, coma, and death. That is mass effect. Coming to the vertebral basilar artery syndrome, occlusions of the vertebral basilar artery system can produce many symptoms with both ipsilateral as well as contralateral signs because some of the tracts in the brainstem will have closed and others will not. Patients will develop acute hemiparesis, rapidly progressing to tetraplegia and lower bulbar paralysis. Initially, the patient will be dysarthritic as well as dysphonic, but it rapidly progresses to mutism. Consciousness and sensation is preserved. Horizontal eye movements are impaired, but vertical eye movements and blinking will remain intact. Communication can be established via these eye movements. Coming to Lacuna syndrome. Coming to Lacuna syndromes, these are caused by small vessel disease which are located deep in the cerebral white matter. They will be associated with hypertensive hemorrhage and as well as diabetic microvascular disease. Okay. Shall I continue with the slides?
Yeah, actually, Dr. Joshi, you've done
Yes,
excellent presentation. Now, these are very important slides. You know, this fast. This is basically to educate the public. So these should be put in the clinic, you know. So I think you must show this. And I would suggest, I'm going to give my comments. You know, AFPI should make an app on this. So this is important. Please go ahead.
Yes, sir. So, spotter stroke fast, face drooping, arm weakness, speech difficulty, time to call 911. Now it has been modified as Be fast. It is important to identify the early signs of stroke. Be fast. These include sudden balance impairment, sudden vision loss in one eye or one field, F for facial droop, A for arm drift. Patient has to close his eyes and extend both arms straight out with the palms up for 10 seconds. S for abnormal speech, T for time to call emergency. So it is Be fast. Step 2 is pre-hospital management as well as how to exclude common mimics. So at first, when a patient is having stroke, if you're suspecting stroke in a patient, how to manage the patient at home before we bring the patient to the hospital. So what we have to do first is we have to assess the airway, breathing and circulation. That is ABC. Then we have to monitor the patient with pulse oximetry. Then we have to start oxygen if the SpO2 is less than 94. Check the patient's blood sugar. Even sometimes hypoglycemia can also present with stroke symptoms. So we have to correct the hypoglycemia if the blood sugar is less than 60. Then we have to exclude the stroke mimics by history as well as physical exam. Like it can be seizure. Patient might have a seizure and he might be having a post-ictal paralysis. It might be a conversion reaction, or it can be hypertensive encephalopathy, or it can be syncope. Then we have to determine the time of onset of symptoms. This is critical because for the patient who presents stroke symptoms, we have to establish the time when the patient was last known to be neurologically normal. If the patient was sleeping and wakes up with symptoms, time last known when is the last time the patient was seen to be normal before sleeping. Then we have to take an ECG to determine if there are any arrhythmias because arrhythmias can certain syncope, etc. We have to establish an IV route, preferably on the non-paralyzed arm. And then we have to avoid dextrose containing fluids. We should give only normal saline for euvolemia patients, and that should be at a rate of about 50 ml per hour. We should also check the blood pressure of the patient. Blood pressure should not be lowered if it is more than if it is more than 220 by 120 millimeter mercury. Then only we should lower. Otherwise, we should not lower the blood pressure. Rapid lowering blood pressure by medications like sublingual methadone intravenous agents should be avoided. Step 3 is pre-notification. We have to update the receiving emergency department so that their staff can prepare for the patient's arrival and begin the therapeutic efforts without delay. We have to transport the patient as early as possible. There should not be any delay in transport. Speed is very vital for the most optimal outcome, and we have to assess the neurological status also while the patient is being transported. So this is just a table showing the target time and so as the time interval. So door to doctor is 10 minutes. It should be done within 10 minutes, and access to the neurological expertise, it should be done within 15 minutes, and door to CT scan completion should be done within 25 minutes. Door to CT scan interpretation should be done within 45 minutes. Door to treatment within 60 minutes, and patient should be admitted in the stroke unit ICU within 3 hours. So this is a table which is showing the NIHS's As we all know, it is composed of 11 items. It has got a maximum score of 42. Then we have to perform a non-contrast CT scan rapidly to rule out whether there is any intracranial hemorrhage. And also we have to rule out any stroke mimics like tumor and estimate tissue at risk of infarction within 25 minutes of emergency department arrival, and it should be independent within 45 minutes. This is a table showing the NIHS score. So if the score is 0, it means no deficit. If the score is 1 to 4, minor stroke, 5 to 15, moderate stroke, 16 to 25, moderate or senior stroke, and if it is more than 25, it means secure stroke. These are the 5 early signs of ischemic stroke on a CT scan. You can see the hyperdense vessel sign, which is the first sign. It is defined as a vessel which is denser than its counterpart and also denser than any non-calcified vessel of similar size. This is a hyperdense vessel sign. Then there is the hypodensity. Hypotension CT is highly specific for irreversible ischemic brain damage if it is detected within the first 6 hours. Third sign is the loss of gray-white differentiation. The fourth sign is sulcal effacement. Effaced sulcine gyri in the hyperacute phase can be seen as shown in the figure. Then the fifth sign is insular ribbon sign. This refers to hypodensity as well as swelling of the insular cortex. Coming to the step 4, decision for IV thrombolysis, the indications and contraindications. So indications within 4.5 hours, 18 years or more, with measurable persistent neurological deficit consistent with ischemic stroke, BP control to less than 180 by 110, glucose more than 50. And additional and also the exclusion include ICH, aortic arch dissection, severe head trauma or ischemic stroke less than 3 months, intracranial or spinal surgery less than 3 months, history of ICH, intracranial neoplasm, acute bleeding diagnosis, etc. Step 5, consider mechanical thrombectomy within 6 to 24 hours. If we have evidence of a large vessel occlusion in the anterior circulation and obtain a perfusion imaging and determine whether the patient is a candidate for mechanical thrombectomy. Mechanical thrombectomy we have to consider for acute ischemic stroke caused by major posterior cerebral or vertebro-basilar artery occlusion, but the benefits are uncertain. This is a summary of the primary management. Acute neurological deficits, stroke suspected. We have to establish when the patient was last known well. We have to look for any collateral history of medical comorbidities. NIHS and symptom severity we have to assess. We have to rule out hypoglycemia and other mimics. Then we have to initiate neural imaging, NCCT, to rule out any hemorrhage. If the last known well is less than 6 hours, IV TPA if there are no contraindications, and last known well within 4.5 hours. Then we have to do a CT or MR angiography, and we have to do a mechanical thrombectomy if any large vessel obstruction is present. If the last known well is between 6 to 24 hours, then we have to do a CT or MR angiography and perfusion. This is followed by a mechanical thrombectomy if a large vessel obstruction is present and it meets the criteria for dawn or diffuse 3. Consider if the last known well is more than 24 hours, then we have to do CT or MR angiography, and that is standard of care based on stroke pathology that we have to do. So coming to the complications of stroke, so there are early as well as late complications. We all know it has early complications include like infection in the chest, or it can be UTI, then dysphagia, constipation, fecal incontinence, DVT, convulsion, motor deficits, spasticity, etc. The late complications include pressure ulcers, pain, allodynia, hyperalgesia, falls, fractures, osteoporosis, contracture, sexual dysfunction, cognitive disorders, memory impairment, dementia, etc. Tertiary management of stroke. This includes cognitive rehabilitation, visual aid, manage aphasia, nutrition, continence, pain, mood and emotional disturbances, post-stroke fatigue, infections, ulcer prevention, prevention of VTE, care against falls, avoiding recurrent stroke. Coming to the prevention of stroke, blood pressure control, diabetes management, smoking cessation, alcohol moderation, carotid artery interventions, liquid management, antiplatelets, anticoagulants, and diet, weight reduction, and exercise. So this is a figure showing the 8 ways to help prevent a second stroke. We have to monitor the blood pressure, control cholesterol, blood sugar down, get active, eat better, lose weight, don't smoke, talk to your doctor about aspirin and other medications. Now, coming to the secondary stroke prevention by stroke etiology. So this is all about aspirin and clopidogrel. So if the patient is having a large artery atherosclerosis, it can be extracranial or intracranial. So if it is extracranial, we have to give aspirin. Then also high intensity statin we have to give. BP should be less than 140 and 90. Lifestyle modification should be there. And also stenting can be done within 2 weeks of TIA or minor non-visible stroke. If the patient is having an intracranial, like 70 to 90% stenotic symptomatic atherosclerotic disease, then we have to start the patient aspirin plus clopidogrel for 90 days. That should be followed by aspirin alone. And also high intensity statin, atorva 80 or 40 we have to give. VP goal should be less than 40 or less than 90 and less than 130 or less than 80 if the patient is diabetic, plus if the patient is diabetic. And also we have to advise for lifestyle modification, angioplasty or stenting, etc. If the patient is having a cardio emboli, then what we have to do is oral anticoagulation, rate control in AF, BP control, etc. that we have to do. And also valve repair or replacement if required should be done. And consider the case of small vessel disease like Laxine. In that case, aspirin do not use for long term. Do not use long term and dual antiplatelets. High intensity statin should be given. Then BP call should be less than 130 and less than 180. If cryptogenic, if the lesion is cryptogenic, then it requires a complete workup. Then consider referral to a vascular neurologist. Aspirin as well as low-dose we have to give. So the burden of stroke on caregivers. Caregivers suffer in different forms. So we have to give them anticipatory guidance. Stairs and wells should be blocked. Cleaning supplies, medications, and other potential poisons, they should be stored safely. Relatives should be counseled on keeping matches and lighters. And all families should be advised to have smoking detectors, etc. So prognosis, the poor prognostic indicators include hematoma volume or expansion, intraventricular hemorrhage, very low GCS, ICH location, deep, age, infection, hypothermia, hyperglycemia or hypoglycemia. 25% of patients die after an acute stroke. 40% will have moderate to severe impairment and require special assistance of care. 10% of stroke survivors will recover completely. 25% will recover with minor impairment. 15% will experience a second stroke in 5 years. So this is the recent advances, acute ischemic stroke decision making. 1988, when the patient comes to stroke symptoms, we will do a head CT, and if the patient is having an acute ischemic stroke, we will admit the patient. 1998, stroke symptoms less than 3 hours from last not well. Then we will do a head CT, acute ischemic stroke, and go to IVTPA protocol like that. Further in 2008, the window period became less than 4.5 hours from last not well. So this is evolution of care of acute ischemic stroke over 2 decades. So the different studies done and all. Multiplies the hours, 0 to 6 hours. Then later it became 3 to 4.5 hours. And currently in 2018 there is the Dawn, Diffuse 3 and etc. is there. Here we use multiplies 4.5 to 24 hours. That interval we use. Then now future may we are currently thinking of this coronary interventions. We are thinking. So over a decade, especially in the past 3 years, acute stroke decision making has become complex and became individualized. First, thrombolytic agent time window defined across population multiplies was 4.5 hours. Then endovascular device and time window defined across the population standard trivosection catheter became 6 hours. Now finally, imaging selection criteria defined who would benefit for the extended time windows out to 24 hours from stroke onset. CTA CTP has been developed for endovascular therapy, and MRI flare diffusion imaging dispatch has come for thrombolysis. So this is the last slide, which is showing the role of a family physician in the multidisciplinary management of stroke. So there should be an early and accurate diagnosis of stroke. Continuous counseling should be there, monitoring should be there, management, as well as there should be a coordination of care. So World Stroke Day is on 29th of October. Thank you.
Well, this is Dr. Kishore Madhwani. Thank you very much, Josie, for an elaborate presentation on stroke after your case discussion. And I must compliment you for making this very, very simple and detailed. This is required. This is an excellent webinar today, and it is because of your case. Now, I would like to add a few points because stalwarts are present today. Raman Kumar ji, Mohan Kubendran ji, Vandana ji, Jyotika Gupta, and many others, all are stalwarts. But the thing is that I must compliment first Josie to make such a lovely presentation. I had seen it yesterday. I found it very big. We have cut 10 slides, but I thought that this much at least we must share. Now, my comments here. First of all, by doing this case, we have come to know that if you know the sequence of events in a stroke with the timing, that will help you in identifying what is the type of lesion, whether it's a ischemia or hemorrhage, and it will also help you to identify where the lesion is. So that is very important in the history taking, and it should come out in the history taking from the time of onset when the symptoms started and how the sequence of events have progressed till one reaches the hospital. Other important thing is, and the risk factors, unfortunately, we have missed out one major important thing, metabolic syndrome. This should have been mentioned. Metabolic syndrome today, the incidence is very high. And it's our patients of metabolic syndrome who are prone to strokes. So we today, GPs, are more of lifestyle physicians. We can be the best because if you know the lifestyle, we can reduce the metabolic syndrome and reduce the probability of developing stroke. Now, this webinar has been done. How many webinars all of us attend and how many are attending today? I suggest to the august body present here today that we should make an algorithm based on the slides which are made by Josie, and few more can be added, and we make an algorithm for stroke. In this, few slides are very important for patient education, especially the slide on fast, be fast, and the 8-step management for stroke. These are very important for patient education. I suggest that we should make an app and an algorithm. And in this, we should have various the diagram which is there on the brain, the different lobes and the signs, the how the symptoms, how the stroke present. That diagram of the brain, if Josie can show, uh, middle cerebral artery and all how it presents, that should be there in that app. That helps the site of lesion. That will help in localizing clinical features. Those slides are also very good, so they should come in the app. This is there. There's one in which all the regions are mentioned: middle cerebral artery, other arteries. There's one diagram of the brain which is there in this in different colors. So that is very important. That should come in the app. These are various lobes and the signs, the diagnosis. It's a diagram is there of lobes and the different symptoms and signs. Then the slides on site of lesion, what are the localizing clinical features, that will help the doctors a lot. Then what to do in a stroke. This slide, please go back. Please go back. These slides are localizing side. This should be there. What is the lobe? What are the functions? So it becomes easy for a doctor to memorize if he's forgotten. And then the other slides which you had sites of the lesion and the localized clinical features, that is also very important. So we should make an app of this. And what to do? What should the doctor do? Step 1, step 2, pre-hospital management, step 3, step 4, step 5, time to interval, everything, it should come in the app. And we can call it as one of the apps that has been made by AFPI under the SPICE route with the leadership of Jyotika Gupta, Josie Ramya. It can be called as Josie Ramya, Jyotika app or whatever we call it. But I think we must do this because how many people attended? If you make something out of this as an app which is useful to people, or at least have it on the website so that a person can refer easily. So I would suggest that we must definitely look into it and summarizing this whole thing, take the good slides and make something concrete which will be useful to all. We must start doing this for all the webinars. Another important thing I would like to share with you, which I think has also been, when we come in practice, we realize. I had a 55-year-old lady who went to one of the reputed hospitals in Mumbai and did a full health checkup. Well, she was fine, but after 1 month, she died. The health checkup was normal. What was the problem? She had an aneurysm in one of the blood vessels of the brain, which burst. Now, that was not picked up in the health checkups. So I have approached the hospitals. So we have started an advanced health checkup for blood, and we also do scanning. The cost of the scanning is 18,000 rupees, but 18,000 is very, very less as compared to the whole body scan. In this, the MRI scan of the whole brain is done, along with this CT angio of the chest and the lungs, and the MRI of the abdomen. So this helps us picking up cancers and other tumors. And this is what we started in Mumbai. And I already have takers. I have a couple of patients who've already done it and they're very happy. And these checks like the CT angio, if there's an aneurysm in the brain, can be done once in 5 to 10 years and affording patients. Why not? Today we have the technology. What if we go to a hospital checkup, everything is normal and the patient dies after 1 month? Well, so aneurysm is another important feature which can burst, and that should have come somewhere in the presentation of stroke. So my sincere appeal to AFPI exec that we should make an app, we should make some material which is useful to everybody, not the few people who are attending here. And I think this we should do for all the good webinars. These are comments from my side. I am ready. If anybody has any questions for Josie, or if anybody else wants to make comments, I would request Raman Kumar ji, Mohan Kumendran ji, and Vandana also to share their thoughts, and also Jyotika. Thank you.
Yes, sir. Wonderfully summarized. We actually have team stroke or code stroke, which is actually active in 2-3 tertiary centers like CMC, or Manipal Hospital, Bangalore. So we realized that if we can come up with such an app that helps the patient transportation, early identification, instead of just saying fast in seminars, if we can translate a classroom like this into something more practical, that will be really meaningful. And it will also mean that we brought out something out of this seminar. So I'd like to briefly summarize the case. Initially, it looked only like a left upper limb, lower limb weakness. So initially, it looked, it could have been just an internal stroke one. But after examination, we just saw that there is one facial drooling, there is hemianopia. So what really looks is not what actually translates. So don't judge a book by its cover. That is one thing. Second thing, CNS and examination is very easy. Just like how Rashmi ma'am very aptly pointed out, it is just like mathematics. You follow the set of rules, you will never go wrong. So PGs out there, don't fear CNS examination. If you get a CNS in your exam.
Dr. Emya, so I'll just add to that. The answer to my question was, Dr. Joshi could have just simply said that MCA supplies the anterior part of the optic radiation, which is in the so and so area. That is what an examiner expects.
Yes.
The posterior part is supplied by posterior cerebral artery, and the anterior part is supplied of the optic radiation is supplied by middle cerebral artery. That answer is what the examiner expects. That's all. I just wanted to add it that time, but didn't want to confuse her so much.
Oh,
okay, carry on.
So sweet, you remember and you made sure you brought it out at the end of the discussion. Second one, examination, there are certain salient points. You follow the format, you will never go wrong. Keep it as higher mental function, motor and sensory. And after that, after that, you do the cranial nerves. And in each one, there are subdivisions, what you do, motor, bulk. And when it is relevant, it's very important. Certain things, everything basic followed, but certain things which we tend to miss out, like ma'am also pointed, is progression. How long it took for the symptom to progress, and how long it took for a symptom to complete. Did the paralysis stop in between, or is it only partial weakness? Is it only complete weakness? This should be ascertained even from the history, not just till the examination. That is one thing we learned today. Second thing, after that, theory part is pretty much straightforward. When we summarize, we should try to use what territory it is involved, why we are thinking that. And when we write differential diagnosis, let us write the most common thing first, and also why we think that. When we write ischemic stroke as first differential, it doesn't mean that we only think that. We should also have negative points. There could be negative points, 1 or 2 points in favor as to why it cannot be ischemic stroke as well. So I wanted to summarize on that. One more thing, advances in stroke, why it is important. Initially, we were told that you can thrombolize only till 3 hours. Now, it has come up to a stage that we can thrombolize about 4.5 hours. So it is giving a slightly prolonged window period time, which means we are actually giving patients a better quality of life. So that we should know. You can do a thrombectomy up to 24 hours, and there is even 30% success rate for thrombectomy even beyond 24 hours. Why we know this? If we know this, we advise the following to the patient. There could be a significant difference in his life. Somebody it can reduce his morbidity. That is one thing. One more thing, we should know what imaging to do when. Somebody immediately comes with a window period stroke. If you can get a diffusion weighted MRI, that is ideal. Or if you can get a CT perfusion. What does CT perfusion tells? How much amount of infarct is there? How much salvageable tissue is left? If this is possible, that can be done. That is why in the clinical studies, we showed that MRI can be done in selected patients or selected institutes. Not available, just do a CT, rule out a hemorrhage, and see if those 5 signs of infarct are there, and go ahead with your window period and protocol. So that much we learned. And our main problem, secondary prevention of stroke. Identify the high risk, prevent the stroke, lifestyle management, focus on metabolic syndrome. It's not only about controlling BP or weight. Check every patient for metabolic syndrome. Do a hip ratio routinely. It's not only about checking FBS, PPBS, HbA1c, weight. No. Do a hip ratio, waist circumference, hip circumference. Do a ratio. Do the lipid profile. Ask if they're sleeping well. Ask if they're mentally healthy. So this will be take home. So if there is any other points, I welcome open discussion. And now the forum is open for questions. Am I audible?
Yeah, you're audible. Do we have any questions from anyone?
Questions? Sir, ma'am, Mohan sir, Soumya ma'am.
Mohan sir has left.
Okay, I just have a comment. Ramya, very well done. Jyotika, superb. Darshana is good, and Josie has done a great job. And all of you present here, I'm sure that you'll have loved this, but we must come out with some concrete thing. Slides made by this girl are excellent. Iska app banna chahiye. This message should be spread and put on the website. App nahi banta hai, to at least, you know, what summary has been given. We should definitely have it so that anybody goes through it in the future. Even I have to go see, I can't remember everything. It is useful for all. So we must have at least 10 to 12 slides, important. And for patient education separate and for us separate. Ye to hona hi chahiye. And please make it a point to do it for all the webinars. That's important. Nahi to hum karte rehte. Kitne log attend karte hain? We have to spread it. हमको ज्यादा भेजना है, लोगों को बताना है, तो we must. हम इतना एफर्ट क्यों करते? जोशी ने इतना मेहनत क्यों किया? खुद ने तो क्या, he has become good at the subject, but बाकी लोग को भी बनने का है ना? What say Dr. Darshana?
Absolutely, sir. So true. We will do that, sir. We will try to put it in the archive on our the Spice Route India.
Try. We have to
Sir,
do.
we will do it.
Try क्या होता है?
No,
Actually,
sir, we will
Dr.
do it.
Nalini has raised her hand. Dr. Nalini, you want to say something?
Dr. Nalini, or unmute.
Or was it an error?
Raman sir, Archana ma'am, can we hear from you, please?
I think Raman sir is not there.
Yeah,
He
Raman
left.
sir is not there. Yeah. Okay, so I think Dr. Preeti. Yeah, Dr. Preeti wants to say something.
Hi, Dr. Preeti here.
You're welcome.
I joined a little late, but even the last little bit I heard, it was just excellent. And if there is a recorded version, just share that link in the group.
There is. It is currently on YouTube. We will share the link. It's the Spice Route India YouTube channel. We'll share it.
Okay. Thank you very much. It was excellent. The last, even the little bit I heard, it's just amazing.
Thank
the work
you.
you all are doing.
Dr. Preeti. Thank you.
Thank you.
Actually, I would like to add,
Yes, Dr.
Josie had done preparation This was a well-prepared version. That's why it's come out excellent. Thanks, Dr. Preeti. And this excellence, 1.5 घंटा किसको है? When I go to my corporates, they say, डॉक्टर तेरे को 1 घंटा कौन सुनेगा? 5 मिनट में बता, 2 मिनट में बता. तो 2 मिनट वाला कुछ तैयार कीजिए. I will help you. We want it. Okay? Thank you.
Okay. So if there is no further question, I would just like to give a vote of thanks to everyone. And it was very nice, informative session. And as we know, as a family physician, we will be a first contact to the patient. And early diagnosis and treatment will make the change in the course of the progression of the disease. And also the prognosis of the patient. Am I audible? Sorry.
Yes, please continue.
Yeah. So as we know, as Dr. Joshi already discussed about the be fast, so that should be the we should remember it and try to find out the diagnosis as early as possible. And as we have discussed, I just want to make one point. There is a score called as a Siri-Raj score, which differentiates between the hemorrhagic stroke from the ischemic. And that is basically a clinical score. So because depending on the headache, vomiting, or level of consciousness, we can try to make out whether it is a ischemic stroke or it can be a hemorrhagic stroke. So it has a few parameters, like for example, headache, vomiting, diastolic blood pressure, and they have given points. So you can just Google it and go through it. So that will be useful for for clinical diagnosis or maybe a provisional diagnosis.
Kiran, I'll interrupt.
Yes, sir.
You have given us information. We are not going to
yes.
Google. You will share. You will help in making it. That एक slide आपका उसमें आएगा. Okay?
Yeah. Sure, sir.
You help us. Yeah. Thank you.
Yeah. Sure, sir. And just want to finish it up fast. So as we there was a a golden period 3 hours, and they were extended to the 4.5 hours, and we have everything we have discussed, that neuro intervention and all that, the time period and everything. So localization and diagnosis is also very important thing. And once we do it, we should not wait for the treatment. So even if you are not able to localize the clinically, we should go for the CT scan, and then depending on the need, diffusion MRI, as Dr. Ramya has said. Also, the physiotherapy and post-op care is very, very important. So we have to play a role here. And along with that, the prevention, primary and secondary prevention, by promoting the healthy lifestyle, avoiding the smoking, and also treating the comorbidities, as Sir said, metabolic syndrome and other dyslipidemia and all that. We have to look for those things, and we have to treat them. So I would like to thank Dr. Joshi for excellent presentation. Also, Dr. Madhwani sir for the moderating the session. I would like to thank all the seniors, Dr. Raman Kumar sir, Dr. Mohan sir, Dr. Ramya, Dr. Jyotika, Dr. Rashmi, Dr. Darshana, and Dr. Vandana. And last but not least, our audience who has joined us, spend their time. And this, as we have discussed, this session will be available also on the YouTube. So you can just share it with your friends and the colleagues. And if there is no further comments, I think we can conclude the session. Thank you.
Dr. Kalinta has her hand raised. Is there anything you want to share with us? Can you unmute yourself, please?
Yes, ma'am. Am I audible?
Yes, you're audible.
It's an excellent session. Congratulations to the Spice Root team and stalwarts in APFI also. There also Dr. Mohan sir and all that. It is a very good one. We can, as sir has suggested, it's good to have some app for the patients wise and one for the clinicians also. And this actually your case has highlighted the importance of family physician. The father of the patient also is a hypertensive, and he has suffered from a stroke and died at the age of 65. And the patient is a hypertensive, and he's also suffered a stroke, and he's also 65 years of age. So actually, if he has a good family physician who would have picked up all the things earlier, it would have been an excellent thing. And I'm sure you're not the family physician for him, because if you are the family physician, earlier you could have taken good care of him and he wouldn't have come up with a stroke now. What do you say? Okay, so this itself is a good evidence that how much family physicians the builders of the healthcare system. Okay, so this is what is coming out everywhere after the COVID also, that family physicians are the main pillar for all the primary health care. It's a good one and excellent. Keep the good clinical work. Okay, congratulations.
Thank you.
I would like to add one thing here. I am going to the Asia Pacific Region Conference at Indonesia, Wonka. And there my paper is the best lifestyle behavior specialist, lifestyle change behavior, or lifestyle behavior change specialist is the family doctor. Because you know the entire family, you know everything. You can influence the change. You can prevent this. So that is the session. And I think we all have to venture into wellness. That becomes another domain for us to do well. Okay. So let us get into wellness, metabolic syndrome and all, prevent all these problems. And we can have, app is going to be expensive. If you're doing an app, it should be for emergency conditions in which one will be stroke, other can be other thing, pancreatitis or something like that. Topics where we need little bit help, right? So we can discuss with Raman Kumar ji and then decide. Thank you.
Thank you, Dr. Kishore. Yes, Ramya, shall we remember? Yeah, Darshana.
So thank you all for joining in. It was our first event, and I'm hoping there will be lots in future. Bear with us, bear with our elaborate sessions. Next time we will try to keep it crisp. It's our first CNS case. We went a little overboard and over excitement. So is there anything you would suggestions? Please let us know. If there is nothing, then we would like to conclude the session. So thank you, Dr. Joshi. Thank you, sir. Thank you, Dr. Jyotika.
Thank you, everyone.
Shall we end the session now?
Yes. Thank you, everyone.
Thank you, everyone. God bless you all. Become
Thank you, sir.
lifestyle
Thank you
coaches.
so much, sir.
Become wellness coaches. Thank you.
Thank you, sir. Definitely.
Thank you, sir.